So I gave you a couple of different things. This, what I did, ChatGPT is our friend. I uploaded the midterm into it and said, create a student study sheet. And it did. Yeah. So it looked at all the questions and created the study sheet. So there should be no reason that you mess up really bad on this midterm.
I'm gonna fail it.
Okay. Yes. Then, this practice EKG and answer, it didn't quite do what I wanted it to do, but what I liked about it when I looked at it, even though there's no picture, it does explain what the rhythm is and what it looks like. So, like, for instance, AFib, irregular, no P waves. That describes AFib. So I figured that might be a good little review. Okay? Asystole, flat line. I think you probably got that down by now. And then there are some practice EKGs. We will do more of those tonight with a little game that I made. But
Can I get the prize box out?
what's in
My prize box.
What is in your prize box?
I honestly don't know. I know the maracas were in there.
Well, it's going to be a station there.
Stickers. I don't know.
You have ducks in there?
I think so. Yeah.
So I can have all my ducks in a row.
Ha. My ducks left.
You have ducks?
I did meet a rooster named Elvis yesterday. I know it's random, but a friend of mine has a rooster named Elvis. All right, so we're going to watch some of these videos. I apologize if you watched them already, but hey, you're not. But it's ACLS, so we have to do some of these.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. Across the United States, survival rates for cardiac arrest, acute coronary syndromes, and stroke vary considerably from region to region.
It's important that EMS, the emergency department, and in-hospital providers work together, not only to deliver better patient care, but to strengthen the chain of survival for future cardiovascular patients.
That starts with identifying the weak points in your system's chain of survival. Gathering data and measuring patient outcomes can identify areas that need improvement.
To deliver the highest quality patient care by using this team approach, there must be an integration of community, EMS, physician, and hospital resources.
This process must focus on prevention and preparedness, immediate recognition of cardiac arrest and activation of the emergency response system, efficient functioning of high-performance teams, including early high-quality CPR with an emphasis on chest compressions, rapid defibrillation, effective advanced life support, integrated post-cardiac arrest care, and recovery.
To deliver the highest quality patient care, integrated systems of care should include in-hospital medical emergency teams and rapid response teams, often referred to as METs and RRTs.
These teams typically consist of healthcare providers with both critical care or emergency care experience and the skills to support immediate intervention for life-threatening situations based on early detection. These teams are responsible for performing a rapid patient assessment and initiating appropriate treatment to reverse physiologic deterioration and prevent a poor outcome.
Some rapid response systems use specific physiologic criteria to determine when to call the team.
The American Heart Association recommends that hospitals establish a rapid response system. In the more than 5 decades since chest compressions were first attempted on a cardiac arrest patient, there have been significant improvements in the treatment of acute cardiovascular disease.
Research confirms that high-quality CPR as a foundation of high-performance teams is crucial for successful resuscitation. Feedback devices have proven beneficial in maintaining high-quality CPR.
But there is much more work to be done, with the latest research pointing to new, quantifiable ways to improve patient outcomes. Advanced providers have more tools than ever before to reduce disability and death caused by cardiovascular diseases and stroke.
All right. Who has the best survival rate in the country? Anybody?
Is it Colorado?
Nope.
Texas.
And it's a city.
State of Missouri.
Texas and Idaho.
Minnesota's pretty good. They're pretty high.
They have that.
They do. Seattle. Seattle Medic 1, King County Medic 1 are the top programs for survival rates in the country. There's a lot of reasons for that. A lot of it has to do with educating the public. Nobody gets a driver's license unless they have CPR. Yeah. So a lot of public service campaigns and community awareness. They are very proud of that statistic and do everything that they can. They also have a resuscitation academy that is known worldwide, that gets run by like the fathers of resuscitation that are still around. So they have it, I think it's twice a year. So people from systems all over the country go to it. So it's really, and I am so excited because the day after I get back from my cruise, I am doing a ride along on King County Medical with my former EMT student that's now a medic out there. So I'm psyched. But yeah, they are like the premier program. So cardiac arrest survival is all about time, right? Nobody sees you fall down, go boom, and die, you're gonna stay dead, right? So it's pretty much, it has to be a witness arrest and somebody has to start CPR right away for you to have a good outcome. By the time we get there, if those things have not been done, then we might get somebody back, but their neurological function is probably not going to be there. Right? Unless there's exigent circumstances like hypothermia, and you know, they were in a snowbank or in cold water, then they have a chance of surviving neurological impact. Otherwise, pretty much not. So, if we get there and they're in asystole, the chances of them getting me back are pretty slim. If they're in VFib or VTAC, that's when we celebrate, because we have a chance of getting them back. CPR prolongs the amount of time that somebody can stay in a shockable rhythm. And did I tell you about my lady with the loop monitor? The implantable monitor that I see?
What monitor?
Oh, it's a implantable monitor that monitors your different heart rhythms. Alright, so this woman was 54 at the time, I think. She had been having syncopal episodes. And they couldn't figure out why. And they did the outpatient, wear the Holter monitor kind of thing. First they did the 24 hours, then they did the 2 weeks, couldn't figure it out. She kept having syncopal episodes, they couldn't catch it. So they put an implantable loop monitor in. Okay. So she gets up, and she wasn't feeling well. It was her granddaughter's christening that day. But she felt kind of dizzy, kind of tired. But she made herself get up and get in the shower. She lived with her adult son. The son heard her fall in the shower. Called 911. They talked him through doing hands-only CPR on her in the shower. Okay. Now, she was not a small woman. And you know how slippery people can be in the shower. State police got there before us, continued CPR in the shower. As soon as we walked in, they're like, "You want us to get her out?" I'm like, "Yeah, great." So They pulled her out, dried her off, and put pads on her, and she was still in defib. Shocked her once, got her back. I was like, that doesn't happen very often. So she, that was on a Sunday. By Wednesday, she was up and talking. By the following Sunday, she walked out of the hospital. Totally neurological. When they looked at her loop monitor, she was in defib for 14 minutes. Because she had great CPR, first by the son, and then by the state police. And then when I got there and was able to shock her, she came right out with one shot. So it was her very lucky day that those things fell in place that she could survive. So many times what happens is those things don't fall in place and somebody doesn't survive, right? So all those things have to happen. So what was really important? Somebody witnessed it. Somebody called 911. They had dispatch-assisted CPR. Not every place in this country has dispatch-assisted CPR. It's crazy, right? He was willing to act and do it. Some people are not. And then state police got there, did really good CPR, and they used to do really bad CPR years ago, but their academy of training has improved over the past 20 years. They used to run from the scene when we got there. They did not want any part of it. Now they're all into it. It's great. So we were able to do our thing when we got there. So that was really cool. And to know that she was in defib for that long and that CPR kept her there. Because it was perfusing myocardium. So it had some energy left to, have some electrical activity. So anyway, that was one of the cooler things that has happened.
How did you find that out after the fact?
I followed up with Vassar, and they were able to go into the chart. And Dave Jensen was still there, so he was able to pull it up and look at it and see. Okay. And then, actually, a couple weeks later, she ended up back in the ER because she was dizzy. She was fine, but another crew brought her in, and I just happened to see her, and she remembered me, so it was kind of cool. I know her address in mind. All right. So, now, is science perfect? No. Does it change? Yes. Okay? Because they're always doing studies. A lot of it is animal studies. Some of it is human studies that they do in Europe. Okay? There's a lot of stuff that we're not allowed to do here that they do in other countries because they just don't care. They don't have lawsuits like we do. But, for a long time it was, let's cool people after we get them back. And they didn't wake up, after a cardiac arrest. Now the focus is on just make sure they don't get a fever. Because we used to cool people to 32, 36, it still says that, but for the most part now it's just make sure they don't get a fever. Because it can cause neurological damage.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. Cardiovascular disease strikes men and women in every nation around the world. From sudden cardiac arrest to the disabling effects of acute coronary syndromes and acute ischemic stroke, cardiovascular disease remains a leading cause of disability and death in many parts of the world. Cardiac arrest occurs in both men and women without warning, or within just a few minutes after symptoms appear. According to most recent statistics, in the United States alone, over 500,000 people suffer from cardiac arrest in just 1 year. On average, only 11% survive. We can improve those numbers. In U.S. cities where healthcare providers make the effort to train and measure their performance with the specific intent of improving performance in the real world, survival rates can be as high as 75%. Understanding and activating the systems of care developed by the American Heart Association is crucial to that success rate. Even more important, fulfilling your role as a member of a high-performance team, focusing on timing, quality, coordination, and administration is the linchpin to providing high-quality emergency cardiovascular care. What you do matters. What you learn can save lives. In adults experiencing sudden cardiac arrest due to ventricular fibrillation or pulseless ventricular tachycardia, the heart is quivering but not effectively pumping blood to vital organs. These patients have a much higher survival rate if they receive immediate chest compressions and early defibrillation. A defibrillator should be used as soon as it is available. If there are 2 or more rescuers present, CPR should be performed while the defibrillator is being attached. When necessary, healthcare providers may tailor the sequence of rescue actions to fit the most likely cause of arrest. For example, in cases involving drowning or other instances where hypoxia is likely cause of cardiac arrest, ventilation becomes much more important than in cases of non-asphyxial arrest. The American Heart Association continues to place a strong emphasis on high-quality CPR. Recent statistics, however, indicate that CPR provided by healthcare providers is often inadequate. To help address this problem, AHA requires the use of audio-visual feedback and prompts devices during training practice and testing, and highly recommends the use during real emergencies for real-time monitoring of CPR quality. So, what is high-quality CPR? First, it is indicated by a rate of 100 to 120 chest compressions per minute, a compression depth of at least 2 inches in adults, allowing complete chest recoil after each compression, chest compression fraction at least 60%, but ideally greater than 80%, avoiding excessive ventilation. Scientific studies continue to link high-quality CPR to return of spontaneous circulation, or ROSC, and to improved survival. High-quality chest compressions maintain blood flow to vital organs, especially to the heart. One way to measure the effectiveness of chest compressions is to monitor coronary perfusion pressure. Coronary perfusion pressure during CPR must reach 15 millimeters of mercury to potentially achieve ROSC. As chest compressions begin, it takes several compressions to raise the coronary perfusion pressure to a level adequate to supply blood to the heart. The higher the coronary perfusion pressure during CPR, the higher the chances of survival for patients. When healthcare providers interrupt chest compressions, coronary perfusion pressure decreases dramatically and remains very low until compressions are resumed. A reasonable surrogate for coronary perfusion pressure is arterial relaxation or diastolic pressure. However, because coronary perfusion pressure or arterial diastolic pressure measurements are not readily available during a resuscitation attempt, healthcare providers can monitor CPR quality with waveform capnography using an advanced airway in place or a bag mask device. An end-tidal CO2 reading of less than 10 millimeters of mercury suggests that achieving ROSC is unlikely. Providers should improve CPR quality by optimizing chest compressions. To perform high-quality chest compressions, healthcare providers should push hard and push fast. Push hard means the provider should compress the chest to a depth of at least 2 inches. The chest should completely recoil after each compression. If it does not, coronary perfusion will remain low. Push fast means to compress the chest at a rate of 100 to 120 compressions per minute. Chest compression rate is directly linked to improved ROSC and survival rates. However, survival rates decline when compression rates exceed 120 per minute because compressions tend to become shallower as speed increases. It can be difficult to maintain the correct depth at such a vigorous pace, which is why the American Heart Association recommends that compressors switch after 2 minutes, or even sooner if the compressor experiences or shows signs of fatigue. Another characteristic of high-quality CPR is minimal interruptions in chest compressions. Studies demonstrate that healthcare providers interrupt compressions far too often and for too long, in some cases spending 25 to 50% of a resuscitation attempt without delivering chest compressions. Chest compression fraction, or CCF, is the proportion of time during cardiac arrest resuscitation when chest compressions are performed. CCF should be, ideally, greater than 80%. Healthcare providers can calculate CCF using a feedback device or manually by using two timers. One timer measures the total code time from code start until code stop or ROST, and a second timer that measures the total chest compression time. Each time chest compressions are stopped, the timer is stopped. The timer would resume when chest compressions are resumed. The chest compression time is then divided by the total code time to equal CCF. Data suggests that lower CCF is associated with decreased ROSC and survival to hospital discharge. CCF is a measurable goal, one that providers should strive to achieve. In line with this, the American Heart Association cautions providers against spending more than 10 seconds checking for a pulse, assessing the patient, or doing anything else other than chest compressions. Finally, in performing high-quality CPR, the rescuer must avoid excessive ventilation. For arrest patients, appropriate tidal volumes should be approximately 500 to 600 milliliters, enough to see visible chest rise. This is about half a squeeze of an adult ventilation bag. Excessive ventilation can not only cause gastric inflation and resulting complications, but also can increase intrathoracic pressure, decrease venous return to the heart, and lower cardiac output and chance of survival. In terms of defibrillation, we emphasize the fluid integration of early defibrillation within high-quality CPR. Healthcare providers should start chest compressions and use the AED or manual defibrillator as soon as possible for the best patient outcomes. Some EMS systems allow responders to provide a period of CPR while preparing for defibrillation. The AHA still recommends the one-shock protocol for VF and pulseless VT.
All right, any questions about that? It drives me absolutely nuts when I see shitty CPR, because you're not giving that patient the chance that they could have. And the same thing when people, they wanna, do all the fancy stuff, but at the end of the day, it's really great CPR and adequate ventilation that's gonna save the patient. All your drugs and all this other stuff is not gonna matter if you're not doing great CPR. So, if you have brand new EMTs that don't know what they're doing, then you have to stop and take the time to coach them and tell them what to do. Even if it slows your stuff down, Do you need an airway right away? You need a BLS airway right away, right? To get all that other stuff done. So defibrillation, your CPR, get your line in and start giving the drugs. As long as there's an adequate BLS airway, then you can throw a king in or a tomato or whatever, Because, and like I said, every time you stop doing compressions, that perfusion pressure goes right back down, you gotta start over. It takes 15 compressions to even get the blood going forward again. So, that's why they pick 30. Alright. Questions about that? No? Yeah, I can tell you all the what's left.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The American Heart Association systematic approach includes 3 components once you have established scene safety and your initial impression of the patient: the BLS assessment, the primary assessment, and the secondary assessment. These sequences combine assessment and treatment components for effective resuscitation. When deciding which assessment to use for a patient, Start with a step we all do automatically. Visually assess if the patient is conscious or unconscious. This is your initial impression of the patient. You can form a rapid general impression by a quick visual assessment of responsiveness, breathing, and color to determine the urgency of the situation. After determining that the scene is safe, if the patient appears unconscious, use the BLS assessment. After completing all of the appropriate steps of the BLS assessment, progress to the primary assessment for more advanced assessment and treatment. Finally, progress to the secondary assessment. If the patient is conscious, go directly to the primary assessment and then the secondary assessment, which we'll review in a moment. For unconscious patients, you'll follow the BLS assessment. First, check for responsiveness. Tap and shout.
Are you okay?
If the patient is unresponsive, shout for help.
He's unresponsive, I need help.
Activate the emergency response system and get an AED or defibrillator. Depending on the circumstances, EMS providers may need to call for additional responders to assist with the patient. In some settings, the healthcare provider may assess the patient's breathing and pulse before activating the emergency response system. Next, check breathing. Scan the chest to detect if breathing is absent or abnormal. Check for a pulse. Ideally, you should check breathing and pulse simultaneously. If you can't feel a pulse within 10 seconds, start high-quality CPR, beginning with compressions. If you determine the patient is not breathing normally but definitely has a pulse, bypass chest compressions and support the patient by ventilating once every 6 seconds. As soon as possible, attach an AED or defibrillator and, if indicated, deliver a shock. High-quality BLS is the foundation for saving lives after cardiac arrest. If these steps are performed rapidly and well, the patient's chance of survival increases. In fact, the effectiveness of advanced life support measures depends on high-quality BLS. In some cases, BLS will result in ROSC, but sometimes cardiac arrest persists, requiring you to continue with more advanced invasive measures. This is when you should follow the primary assessment and secondary assessment. Another time to use the primary and secondary assessments is if a patient is conscious. You can easily remember the steps of the primary assessment by thinking A, B, C, D, E. Keep in mind that although these steps are listed in progressive order, the resuscitation team often performs them simultaneously. A stands for airway. For unconscious patients, healthcare providers should maintain a patent airway and consider inserting an advanced airway device. Regardless of the device chosen, the resuscitation team must ensure proper placement and use waveform capnography to monitor effectiveness. Conscious patients can often maintain the integrity of their own airway, and healthcare providers need only ensure patency by providing suctioning if needed. B represents breathing. If the patient is not in cardiac arrest, healthcare providers should assist ventilation as needed once every 6 seconds. If the patient does not require assisted ventilation, healthcare providers can support the patient by administering oxygen as needed. C involves supporting the patient's circulation. Attach ECG leads, obtain intravenous or IV access, or intraosseous or IO access. Give appropriate drugs to manage abnormal rhythms, and assess for perfusion issues. You are collecting a wide range of information, including blood pressure, heart rate, and cardiac rhythm. Additional data, such as temperature and glucose levels, may further refine the initial interventions needed. The A, B, and C steps provide a continuous stream of information about the progression of the patient's condition. D stands for disability. This involves checking for neurological function, quickly assess for responsiveness, levels of consciousness, and pupil dilation. A quick tool that can be used to evaluate neurological status is AVPU, alert, voice, painful, and unresponsive. Finally, E involves exposing the patient. Remove clothing to perform a physical examination, looking for obvious signs of trauma, bleeding, burns, unusual markings, or medical alert bracelets. The secondary assessment involves the differential diagnosis. This involves obtaining a focused medical history and searching for and treating reversible causes. You may naturally jump to some possible diagnoses as soon as you evaluate the patient. However, before arriving at a definitive diagnosis, you'll need to assess the patient and gather additional information about the condition. Gathering a focused history of the patient is recommended. Ask specific questions related to the patient's presentation. Consider using the memory aid SAMPLE. Signs and symptoms, allergies, medications, including the last dose taken, past medical history, especially relating to the current illness, last meal consumed, and events, especially ones that may have led up to the current illness. The answers to these questions can help you quickly rule in or rule out suspected diagnoses. Next, look for and treat the underlying cause by considering the H's and T's to ensure you are not overlooking a dangerous or likely possibility. The H's and T's create a roadmap for possible diagnoses and interventions for your patient. Let's review these now. Hypovolemia is low blood volume. Hypoxia occurs when inadequate oxygen is reaching the body's tissues. Hydrogen ion or acidosis is the accumulation of acid and hydrogen ions in the blood and body tissues. Hyperkalemia is an abnormally high concentration of potassium ions in the blood. Hypokalemia is low blood potassium. Hypothermia is when the body temperature drops below 95 degrees Fahrenheit or 35 degrees Celsius. Tension pneumothorax results from an abnormal accumulation of air in the pleural space. Cardiac tamponade is a condition caused by an accumulation of fluid between the heart and the pericardium. Toxins may be best uncovered by a focused history. A pulmonary thrombosis or pulmonary embolism is a blood clot from a large vein that breaks off and travels to the pulmonary artery where it becomes lodged. A coronary thrombosis is a blood clot that forms within a blood vessel of the coronary system. Intervening and stopping a patient's downward spiral is the ultimate goal of the BLS, primary, and secondary assessments. The American Heart Association has developed a truly systematic approach that can facilitate optimal care. By following the assessments in tandem with an adherence to the chain of survival, you will more efficiently and effectively assess, diagnose, and treat your patients. Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves.
Leticia,
Hey Jack, what's up?
happy Monday. When you finish with this, I need you to clear up the end cap down there. I got a whole bunch of promotional items coming in. We got to put them somewhere.
Okay, sounds good.
Oh,
You all right, Jack?
yeah. Yeah, I'm fine. I think it's that stuff that everybody's got going around.
Okay. Acute coronary syndromes, or ACS, may suddenly strike men and women, often after years of asymptomatic coronary atherosclerosis and plaque formation. As plaque forms within the coronary arteries, several clinical syndromes may also develop, with varying degrees of coronary artery occlusion. Two of these syndromes are non-ST segment elevation acute coronary syndromes, or NSTE-ACS, and ST segment elevation myocardial infarction, or STEMI. STEMI is generally considered to be more serious and usually develops after a ruptured plaque or an erosion results in an acute blood clot that significantly or completely occludes a coronary artery. Either of these syndromes can, unfortunately, manifest as sudden cardiac arrest and death. It's estimated that half of the deaths from these syndromes occur outside the hospital, making early recognition and rapid response essential. The best outcomes from ACS occur in communities where programs with strong public education, PAD programs, and STEMI systems of care exist. Watch how emergency medical services and hospital personnel use the STEMI chain of survival to provide a system of care that recognizes and rapidly treats the underlying causes of ACS.
What's going on?
I think Jack's having a heart attack. I'm gonna call 911. You get the AED and first aid kit.
Okay.
911, what is your emergency?
I think my manager's having a heart attack.
I see you're located at 459 Commerce Avenue, is that correct?
Yes.
Where is the patient?
He's right here. He was wobbly on his feet, so we sat him down in the aisle. He's having chest pains and his left arm hurts.
Is he awake? Can you talk to him?
Yes, he's awake and able to talk.
I'm going to dispatch paramedics to your location. Stay on the line with me, okay? Don't hang up. I'll have a few more questions to ask you.
Okay.
All right. So, what was that classic sign that he had? Loving sign, yes. He didn't look great, and it was a sudden onset. So, probably ruptured a piece of plaque, right? Has a blood clot. All right.
The first step in the ACS algorithm involves the patient, bystanders, and medical personnel recognizing the warning signs of cardiac ischemia.
We all had basic first aid training and CPR training about 6 months ago. And when Jack said his chest was hurting and his left arm was hurting, that's when the alarm bells went off for me.
Our system uses priority dispatching protocols, which help identify the problem and determine what type of response to send. What the caller described fit the protocol for ACS, which required a high priority EMS response.
While waiting for EMS to arrive, dispatchers may advise patients to chew 162 to 325 milligrams of non-enteric coated aspirin. This recommendation should be in line with approved medical protocols, and only if the patient has no history of true aspirin allergy or gastrointestinal bleeding.
Okay, paramedics are on their way. Stay on the line with me until they arrive. Do you have a first aid kit with you?
Yes, and I have our AED too.
Great. Is the patient still conscious?
Yes, he is.
Okay, then we won't need to use the AED right now. Ask if he has an aspirin allergy or any recent bleeding from his stomach.
Jack, do you have an allergy to aspirin?
No,
Have you had any bleeding in your stomach recently?
no, I don't think so. No.
No to both questions.
Look in the first aid kit. If it has aspirin, have him chew 2 to 4 baby aspirins or 1 adult aspirin while you wait for the paramedics to arrive.
That brings us to the next step in the ACS algorithm: assessment, care, and hospital preparation.
What happened?
He's been having chest pains for about 10 minutes, and the 911 operator said to give him an adult aspirin to chew.
Sir, how you feeling?
Not so good. It's my chest. I feel like somebody's squeezing it.
Okay, well, we're gonna help you out, reduce that pain. I'm gonna get a 12 lead, go ahead and get his blood pressure and put him on pulse ox. When we arrive on scene, the clock is ticking. I know I've got to assess, but if he doesn't need immediate resuscitation, my highest priority is to obtain a 12 lead ECG, manage the symptoms, initiate transport as soon as possible. Every minute matters. The longer it takes to get to the hospital, the poorer the outcome for the patient. In fact, half the people who die from ACS are dead before they even reach the hospital, so I follow the ACS algorithm closely just to make sure that doesn't happen.
Administer supplementary oxygen if the patient's oxygen saturation value is less than 90%. Give aspirin if the patient hasn't taken any yet and there are no contraindications. It's critical that out-of-hospital healthcare providers obtain a 12-lead electrocardiogram.
Looks like a STEMI.
You need to be shaved.
This early ECG helps classify patients suspected of having an ACS into two groups based on ST segment deviation before they reach the hospital. It's preferred that patients with ST segment elevation be driven, if feasible, to a hospital that performs primary PCI. This initial ECG speeds the patient's diagnosis and shortens the time to reperfusion.
Recognizing ST segment elevation on a 12-lead ECG takes training and practice because different thresholds exist for patients depending on their age and gender.
If a STEMI is suspected, EMS should notify the hospital or transmit the ECG for interpretation.
All right. So, do you think they got a good 12 lead? With that guy's hairy chest? No, he needed to be shaved to get a decent 12 lead. How fast should you get a 12 lead? Within how many minutes of arriving on scene?
5.
At least 5 to 10, the longest, okay? Because you want to identify quickly what's going on with them and let the hospital know, because we only have one patient, they have 60 or more, right? And it takes time to get the cath lab up and running, especially if it's nighttime, right? So that's why you want to do that quickly. In terms of aspirin, they don't know which dose is the most effective. Like, they don't know if it's 1, 2, or 4. So that's why they say give 2 to 4. Okay? Obviously, you're going to follow whatever your local protocols are, but aspirin is the only thing that is proven to increase or decrease mortality. Okay? Nitroglycerin doesn't have any proof that it decreases mortality. Pain meds don't. It just makes the patient more comfortable. But aspirin reduces mortality. So it's really important. When people tell you they're allergic to aspirin, what's your next question?
Why?
What happens when you take it? Okay? Because a lot of times it's not really a true allergy. It's just that their doctor told them not to take it because it hurts their belly. Okay? Or they had a GI bleed, or whatever the case may be. Okay? If they tell you they break out in hives and have difficulty breathing, okay, then it's an allergy. But most of the time, it's not. Okay. What else? That's most of it for that video. Alright, bonus time.
The patient had ongoing symptoms of ischemia, so we administered nitroglycerin sprays every 3 to 5 minutes for a total of 2 doses. 3 is the max. We monitored the patient's blood pressure between each dose.
Before giving nitrates in any form, make sure there are no contraindications, such as severe bradycardia, tachycardia, or hypotension. Also, confirm that the patient hasn't taken any phosphodiesterase inhibitors for erectile dysfunction in the past 24 to 48 hours. Patients with inferior wall STEMI on their 12-lead ECG can often have right ventricular involvement. This can be confirmed by a right-sided 12-lead. If RV infarction is present or suspected, nitrates in all forms are contraindicated. Clinically, it may be suspected in patients with hypotension, clear lungs, and elevated JVD. If the patient receives nitroglycerin but does not experience pain relief, healthcare providers can consider giving analgesics, such as morphine, while monitoring the patient's blood pressure and respiratory rate. Use morphine with caution for patients with unstable angina.
County Medical, this is Rescue 1. We've got a STEMI alert. 46-year-old male, chest discomfort started half an hour ago. Current vital signs are BP 104/78 with a heart rate of 96. Pulse ox 95%. He's chewed 325 milligrams of aspirin and received 2 rounds of nitroglycerin sprays, but still says he has chest discomfort. 12 lead shows ST segment elevation of 3 to 4 millimeters in leads V1 through V4. ETA to your facility is 10 minutes.
Rescue 1, we received your 12 lead and your initial report. We'll activate our heart alert system, contact the cardiologist and the cardiac cath team. Getting this advance notice really helps us speed treatment of these patients, increasing their chance of survival. We can have the cath lab prepped and ready by the time the patient hits the doors of the ED.
The American Heart Association recommends that EMS personnel transport patients who have a STEMI to the closest appropriate facility that provides reperfusion without delay. Based on hospital local protocol and cath lab team being prepped and in place, it is best practice to bypass the ED and take the patient straight to the cath lab where initial evaluation can take place.
Studies show that ED evaluations are responsible for as much as 33% of the total time from symptom onset to treatment. We try to reduce delays by having everything ready when the medics arrive. After seeing the 12 lead that the medics had sent, I immediately activated the PCI team and alerted the cardiologist.
When the patient arrives at the ED, we move to the next step in the ACS algorithm. Reperfusion goals for STEMI patients include PCI within 90 minutes after the first medical contact, or fibrinolytics within 30 minutes from ED arrival. The appropriate therapy is defined by patient and center criteria. Within the first 10 minutes after arrival, staff should provide an immediate assessment of the patient. That includes taking vital signs, getting a brief, targeted medical history, completing a fibrinolytic checklist, and obtaining blood studies. If the early ECG shows no signs of ST segment elevation, then a repeat ECG in the ED is warranted. The staff should also get a chest X-ray within the first 30 minutes after arrival. In addition, draw a STEMI panel. Adjunctive treatments include unfractionated or low molecular weight heparin, bivalirudin, P2Y12 inhibitors, IV nitroglycerin, beta blockers, and glycoprotein 2B3A inhibitors.
Hi, I'm Dr. Taylor.
Hi, how is he? Did he have a heart attack?
I'm afraid so, but his vitals are improving. Dr. Abrams is an excellent cardiologist, and he'll be going over the next steps with you. You'll be in good hands with him, okay?
This patient presented with ST segment elevation of 3 to 4 millimeters in leads V1 through V4. Now, this suggests that his LAD artery is occluded. Immediately opening up the artery with PCI and restoring normal blood flow is my primary goal.
The final link in the STEMI chain of survival is treatment. The preferred reperfusion strategy for STEMI patients is PCI.
Hi, Mr. Brennan, I'm Dr. Abrams, your cardiologist. How you feeling?
Not so good.
Well, hopefully you'll be feeling a lot better soon. I just want to talk to you a little bit about what's going on. I reviewed your ECG, and it appears you have a blockage in one of the arteries to your heart. Now, to open the artery, we need to perform a procedure called PCI that will help reestablish blood flow to your heart. Basically, we insert a catheter into the artery with the blockage and inflate a balloon to widen the blocked area. We then place a stent to keep the artery open. And the sooner we can do this procedure, the less damage may be done to your heart. Okay?
Okay. I understand. I'm ready.
All right. Let's see what we can do to help you get better, okay? All right.
So, what did they say was best practice that we don't do around here? They were talking about best practices. What is it that we don't do around here? Where do the patients go first? Right? So, instead of going right to the cath lab, they stop in the ED. There are systems out there where, and triage can do this too, that the 12 lead will go right to the cardiologist. And they will make the decision. So it speeds things up. Why does this not happen? All over? Hospital politics. And, and money. Because the ED wants to be able to bill for their visit. Yeah. So it's not all about saving lives when it comes to hospital politics. And some of the cardiologists are concerned about their statistics. that is especially true in one facility around here. So they don't always want to take the patient to the cath lab if they think they're gonna die, because it will mess up their statistics. Yeah, so, I've seen that happen with some of my patients, and it makes me very angry, and I've instructed my wife as to what to do if that ever happens to me.
Fight? Fighting?
I told her, to make sure that, tell the doctor that his, malpractice insurance is paid up because he really gave because it's ridiculous. I mean, these are people's lives. Why would you not try? You know? Anyway. Something else I hope changes with Northwell, because I don't think Northwell will put up with that.
PCI opens the blocked artery with a tiny balloon. Then a stent, or metal scaffold, is inserted to maintain blood flow to the heart. When choosing between this reperfusion strategy and fibrinolytic therapy, hospital personnel must consider a number of factors. Studies show that treatment delays increase mortality in both groups, regardless of the reperfusion strategy chosen, but were more pronounced among those patients receiving fibrinolytic drugs. In these cases, the more time that goes by, the more heart muscle is lost. The better EMS systems and medical centers work together, and the faster they can deliver treatment, the more heart muscle and patients can be saved.
We had a great outcome with that patient, but we wouldn't have if every link in the chain hadn't been working cohesively.
All the pieces fit together perfectly, and it all began with a call from his coworker. The dispatcher assisted in the administration of aspirin prior to our arrival. We were able to get to him in time, identify a STEMI, and move him quickly to a hospital where they were ready to do PCI. He's back at work today because of it.
So, they also talked about giving morphine for pain relief, which makes me crazy, because they're the ones that said Mona was dead. Morphine, oxygen, nitro, aspirin. So I don't know why they're still talking about morphine, but fentanyl is the preferred agent, because morphine causes a histamine response, also causes more nausea, so then you have to give another drug, right? So fentanyl is the preferred agent. So the younger doctors will all give fentanyl, and the saying is fan the chest pain, so fentanyl, aspirin, nitro. Okay? They also said that nitroglycerin is contraindicated. It is not contraindicated. You have to use it with caution if you have an inferior wall MI with right-sided involvement. Okay? What else? These are due to be updated, let's put it that way. It's been 5 years. They update them every 5 years. So the new guidelines did come out. There wasn't like major stuff, but they need to update some of their reviews. Alright. So, if you have, I mean, you're gonna get out there and you're gonna see some of these people's 12 leads and you're gonna be like, what the hell is that? Right? So if you're not sure, just send it to the hospital and let them look at it. Okay? Most of the equipment that I unfortunately have to use does not actually transmit a 12 lead. I have to send it over triage. So, make sure you say in triage, please make the doctor look at this. Okay? And then sometimes I will call med control and say, hey, did you see that 12 lead? Because some of the Zolmoners won't transmit. The ones in Wapengers for some reason do not. So, yeah, I mean, I've looked at thousands of 12 leads, but sometimes I look at them and I'm like, what is that? You know, and we're at a distinct disadvantage because we don't have a previous 12 lead to look at. Whereas at the hospital, they do. So if you send their info over triage, they can pull up their charts and look at their previous 12 to see if it's a new left bundle branch block or not. Because if it is a new bundle branch block, it could mean that they are having an MI. Right? But we don't know that because we don't have that information, but the doc can look at that before we get there. Questions about that? All right, why don't we take like a 10-minute break, get yourself around so you don't die.